Self-expandable metal stents for obstructing colonic and extracolonic cancer. European Society of Gastrointestinal Endoscopy, ESGE Guideline, Update 2020. Introduction. Colorectal cancer is one of the most common cancers worldwide, particularly in the economically developed world. Large bowel obstruction caused by advanced colonic cancer occurs in 8% to 13% of colonic cancer patients. The management of this severe clinical condition has been controversial. Over the last decade, many articles have been published on the subject of colonic stenting for malignant colonic obstruction, including randomized controlled trials, RCTs, and systematic reviews. Thereby, the role of self-expandable metal stents, SEMSs, in the treatment of malignant colonic obstruction has become better defined. This evidence and consensus-based clinical guideline has been developed by the European Society of Gastrointestinal Endoscopy, ESGE. It is an update of the previously published guideline and aims to put into perspective the new evidence that has become available over the last 5 years, and to provide statements regarding the use of SEMS in the treatment of malignant colonic obstruction. With the exception of one trial, all published RCTs on colonic stenting for malignant obstruction excluded rectal cancers, which were usually defined as within 8 to 10 centimeters of the anal verge, and colonic cancers proximal to the splenic flexure. Rectal stenting is often avoided because of the presumed association with complications such as pain, tenesmus, incontinence, and stent migration. Proximal colonic obstruction is generally managed with primary surgery, although there are no RCTs to support this assumption. Because of the aforementioned limitations, unless indicated otherwise, the recommendations in this guideline only apply to left-sided colon cancer arising from the rectosigmoid colon, descending colon, and splenic flexure, while excluding rectal cancers and those proximal to the splenic flexure, and other causes of colonic obstruction, including extracolonic obstruction. Methods. ESGE commissioned this guideline and appointed a guideline leader, Van Hooft, who invited the listed authors to participate in the project development. The key questions were prepared by the coordinating team, Veld and Van Hooft, and then approved by the other members. The coordinating team formed task force subgroups, each with its own leader, and divided the key topics among these task forces. Each task force performed a systematic literature search to prepare evidence-based and well-balanced statements on their assigned key questions. The coordinating team independently performed systematic literature searches with the assistance of a librarian. The Medline, Embase, and Cochrane library databases were searched, including at a minimum the following key words: colon, cancer, malignancy or neoplasm, obstruction, and stents. All articles studying the use of colonic stenting for malignant large bowel obstruction were selected by title or abstract. After further exploration of the content, articles containing relevant data were then included and summarized in the literature tables of the key topics. All selected articles were graded by the level of evidence and strength recommendation according to the Grading of Recommendations Assessment, Development, and Evaluation (GRADE) system. The literature searches were updated until July 2019. Each task force proposed statements on their assigned key questions, which were discussed and voted on during the plenary meeting held in September 2019, Amsterdam, the Netherlands. An overview of the statements of the previous guideline published in 2014 versus the updated statements was created. In October 2019, a draft prepared by the coordinating team was sent to all group members. After agreement of all members had been obtained, the manuscript was reviewed by 2 external reviewers and was sent for further comments to the ESGE national societies and individual members. After this, the manuscript was submitted to the journal Endoscopy for publication. All authors agreed on the final revised manuscript. This guideline was issued in 2020 and will be considered for review in 2025 or sooner if new and relevant evidence becomes available. Any updates to the guideline in the interim will be noted on the ESGE website, www.esgeguidelines.html. Main recommendations. The following recommendation should only be applied after a thorough diagnostic evaluation, including a contrast-enhanced computed tomography (CT) scan. ESGE recommends colonic stenting to be reserved for patients with clinical symptoms and radiological signs of malignant large bowel obstruction without signs of perforation. ESGE does not recommend prophylactic stent placement. Strong recommendation, low quality evidence. ESGE recommends stenting as a bridge to surgery to be discussed within a shared decision-making process as a treatment option in patients with potentially curable left-sided obstructing colon cancer as an alternative to emergency resection. Strong recommendation, high-quality evidence. ESGE recommends colonic stenting as the preferred treatment for palliation of malignant colonic obstruction. Strong recommendation, high-quality evidence. ESGE suggests consideration of colonic stenting for malignant obstruction of the proximal colon either as a bridge to surgery or in a palliative setting. Weak recommendation, low-quality evidence. ESGE suggests a time interval of approximately 2 weeks until resection when colonic stenting is performed as a bridge to elective surgery in patients with curable left-sided colon cancer. Weak recommendation, low-quality evidence. ESGE recommends that colonic stenting should be performed or directly supervised by an operator who can demonstrate competence in both colonoscopy and fluoroscopic techniques and who performs colonic stenting on a regular basis. Strong recommendation, low-quality evidence. ESGE suggests that a decompressing stoma as a bridge to elective surgery is a valid option if the patient is not a candidate for colonic stenting or when stenting expertise is not available. Weak recommendation, low-quality evidence.